Welcome, ladies and gentlemen. Currently, scientific evidence pertaining to implant occlusion is inadequate, limited to mainly in vitro, animal, and retrospective studies. Therefore, this lecture is trying to discuss the importance of occlusion in implant dentistry for implant longevity and to provide clinical guidelines of recommended implant occlusion. Let us start. There are some studies have suggested that occlusal overload may contribute to implant bone loss or implant late failures. However, there are some other studies believe that peri-implant bone loss or loss of osseointegration are mainly associated with biological complications. At present, most researchers have suggested that occlusal overload can cause mechanical complications on dental implants and implant prostheses. This systematic review discussed the clinical complications, which were associated with implants and implant prostheses. The authors have suggested that the implant prostheses have more mechanical complications than conventional prostheses. This table has shown that mechanical complications of implant prostheses. There were a lot of mechanical complications stated in this table might be due to overloading, such as veneer fracture, overdenture fracture, opposing prostheses fracture, screw loosening and so on. This is another systematic review paper discussed the complications of implant crowns and fixed partial dentures, including crown chipping, screw loosening, failed retention, fracture screw and fracture implant. Occlusal loading might have contributed to all these mechanical complications here. Kinsel and Lin have done a retrospective study regarding porcelain failures of implant prostheses. They reported that 94 units prostheses fractured. They also revealed that 7 times odds of porcelain fracture if opposed by implants, and 7 times odds if bruxist and not wearing stabilization splint. This table is comparing tooth and implant, regarding their connection, proprioception, tactile sensitivity, axial mobility, movement phases, movement patterns, fulcrum to lateral forces, load-bearing characteristics and signs of overloading. I would like to ask a question. Do implants move? Most of the people will say, no. However, we must remember, implant fixture, implant superstructure and bone might get deformation. There were a lot of contradicting studies regarding the relationship between bone loss and occlusal loading, such as the studies listed in this slide. There are a few overloading risk factors for implant prostheses, including cantilever length, parafunction activity, premature contacts, bone quality, tooth morphology, cuspal inclination and number of implants. At present, the correlation between implant bone loss and overloading induced by cantilevers remains unclear. However, with regards to the cantilever length, there was a clinical study demonstrated that long mandibular cantilevers, 15 mm, induced more implant prosthesis failures. Therefore, increase the number of implants and implants placement not in a straight line might be useful to reduce the cantilever effect. These periapical radiographs have shown you some examples of cantilever implant prostheses. The previous slide has shown you the study by Kinsel and Lin, regarding the mechanical complications of implant prostheses associated with bruxism. There was a study suggested that inline placement, leverage factors, and bruxism or heavy occlusal force as the possible causes of implant fracture. However, there was another study stated that no notable correlation was found between implant marginal bone loss and load-related factors, such as bite force and cantilever length. Therefore, the different results between the studies might have been attributed to individual variability of the patients and prostheses and differences in occlusal designs. This image has shown you an example of severe worn implant-supported bridge associated with bruxism. Premature contact is defined as an occlusal contacts that divert the mandible from a normal path of closure, interfere with normal, smooth, gliding mandibular movement. It will result in excessive occlusal loading on the prostheses. Loss of osseointegration and excessive marginal bone loss from excessive lateral load provided with premature occlusal contacts were demonstrated in several animal studies as stated in this slide. These images have shown you an example of premature contact on upper right 6 and lower right 5. Bone quality has been considered the most critical factor for implant success, and it is therefore suggested that occlusal overload and poor quality bone might affect the implant longevity. There was some studies reported that higher failure rates of implants were observed in bone with poor quality. Esposito and his group reported that combination of poor bone quality and overloading were the causes of late implant failure. There are several prosthetic considerations concerning occlusion, including superstructure failure, fracture or loosening of screws, veneer fractures, prognosis of implant prophysis, shock adsorption of occlusal loads and occlusal design. These images are some examples of mechanical complications of implant superstructures, including fracture of screws, fracture of abutment, worn prosthesis, worn attachments and fracture of bar clip, and most of them might be associated with occlusal overloading. The types and basic principles of occlusion in implant dentistry are mainly derived from occlusal concepts in natural dentition. Three most commonly adopted occlusal concepts, including balanced occlusion, group function, and mutually protected occlusion. Besides, fabrication of tooth morphology to induce axial loading is an important factor to be considered when constructing implant restorations. This is because of axial loading can be well distributed along the implant bone interface, and the cortical bone can resist the compressive stress favorably. Implant protective occlusion is developed by MISH. It helps to reduce stress to the implant interface, including no occlusal interferences, influence of surface area, mutually protected articulation, implant body angle to occlusal load, cuspal inclination, cantilever distance, crown height, occlusal contact positions, implant crown contour, protect weakest component and occlusal materials. As suggested by Kim and researchers, the basic principles of implant occlusion are anterior guidance, bilateral stability and maximum intercuspal position, wide freedom and centric, evenly distributed occlusal contacts, no centric interference and smooth lateral excursive movements. How to check occlusal contacts of implant restorations. Initially, light force and shim stock are first used to evaluate the maximum intercuspal position. Contact places heavier contacts on the adjacent natural tooth. Then, greater occlusal force is applied. Equal contacts should be established on implants and natural teeth. Last, check the lateral and protrusive guidance. This image shows heavier contacts on the adjacent natural tooth. With regards to anterior guidance, anterior teeth should disocclude the posterior teeth during lateral excursion and protrusion. However, if implant restoration involving guidance, try to provide a shallow guidance. These images have shown implant prostheses on premolar and molar were protected by canine guidance. The natural tooth always has steep cuspal inclines. The greater cusp angles may help to improve chewing efficiency, but the occlusal contact along the angled cusp results in lateral loads. Therefore, reduced cusp inclination, shallow occlusal anatomy, wide grooves or fossae will provide an axial loading, which reduce the noxious effect of lateral loads as showed in this image. Pertaining to occlusal table width, 30% reduction in a molar will reduces the cantilever effect, and reduces the chances of offset loading. Subsequently, improve oral hygiene and reduce porcelain fracture. This image has shown reduced occlusal table for premolar implant prostheses. Sometimes, we might consider crossbite occlusion to avoid buccal cantilever and increase the axial loading for maxillary posterior implants due to bone resorption. To protect the maxillary implants, we might need to consider increase the number and diameter of the maxillary implants, splint them together to distribute and share the occlusal loading. Bone augmentation might be needed for some cases. These images show splinting of both implants to share the occlusal forces during the lateral excursive movement. The occlusion in a single anterior implant should be designed to minimize occlusal force onto the implant and to maximize force distribution to adjacent natural teeth. Any anterior and lateral guidance should be obtained in natural dentition. In addition, working and non-working contacts should be avoided in a single restoration. Light contacts at heavy bite and no contact at light bite and maximum intercuspal position are considered a reasonable approach to distribute the occlusal force on teeth and implants. Restoring missing canine is a big clinical challenge due to canine always involves in guidance. However, opposing natural tooth might provide some proprioceptive feedback to avoid overloading. Increasing the size of implant or design the guidance in group function might be alternative solutions. With regards to short-span posterior implant restoration, occlusion could be designed in anterior guidance in excursions, and initial occlusal contact on natural dentition will reduce the potential lateral force on implants. Group function occlusion should be adopted only when anterior teeth are periodontally or structural compromised. Clearance on light contact and contact on maximum intensity normally conformative approach, narrow occlusal table and shallow cuspal inclines. Regarding Kennedy 1 and 2 cases, the prescribed occlusion is same as short-span posterior implant restoration. For bilateral distal extension cases, implant in light contact to prevent natural tooth overloading. With regards to extensive anterior implant restorations, just like other implant restorations, clearance on light contact and contact on maximal intensity and maximum intercuspal position. Must maintain contacts on posterior teeth and provide shallow anterior and canine guidance. For full arch fixed implant prostheses, balanced occlusion has been utilized for an opposing complete denture, while group function occlusion and mutually protected occlusion with a shallow anterior guidance have been widely adopted for opposing natural dentition. Bilateral and anterior-posterior simultaneous contact-centric relation and maximum intercuspal position should be obtained to evenly distribute occlusal force during excursions regardless of the occlusal scheme. For the occlusion on implant retained over dentures, it has been suggested to use bilateral balanced occlusion on a normal ridge. On the other hand, monoplane occlusion was recommended for a severely resorbed ridge. However, there are no clinical studies which demonstrate the advantages of bilateral balanced occlusion for implant retained over denture occlusion compared with other occlusal schemes. It is always advisable to prescribe a hard stabilization splint after implant therapy, especially for bruxers, full mouth reconstruction cases and patient with heavy occlusal forces. As a conclusion, these are the factors to consider in implant occlusion, including increased surface area, improve force direction and reduce force magnification.